Now that you've learned about evaluating cognitions, let's talk about how you help clients remember what they learned through this evaluation process. First, we'll talk about negative cognitions that you have evaluated with the client in the session. After evaluating an automatic thought, you want to help the client draw a conclusion and then make sure that that conclusion is written down. You can use one of the following questions to help a client draw a conclusion. What do you conclude about all this? Or, can you summarize what we've just talked about? Or you can phrase it this way: what do you want to remember? Or, what would be important for you to remind yourself this week? And then finally, if it's relevant, what do you want to do this week? Then it's so important to record this response. Research shows us that people forget between 40 and 70% of what they hear in a healthcare provider's office. I think they forget so much more in a therapy office. So here's a good rule. Anything that you want a client to remember had better be recorded in some way. Either you or the client could take notes on a piece of paper, in a notebook, on an index card, or the client can use his or her smartphone, either by taking notes or by making an audio recording of the conclusions. So what do you do if a client gives you an inadequate summary? Well, you can always say, I think that's close, but I wonder, maybe it would be more helpful if you remembered it this way. And then you can supply the summary and see if the client agrees with it. In other cases, clients give a good summary, but it's too brief. And then you might suggest, do you think you might also want to remember this or that? And then, if the client agrees, add these new statements to the summary. Here's a good summary that Sophia recorded. When I think there's too much to learn, remind myself that I don't have to learn it all overnight. I have lots of time. Most likely, I'll be able to learn the basics and then I can keep learning more. When I tell myself there's too much to learn, I get overwhelmed. It's better just to focus on what I need to learn that day. I'll also feel less overwhelmed if I block out time in my schedule so I can see when I'm going to study. In this next part, let's talk about how do you help clients evaluate and respond to their automatic thoughts between sessions. Now, if you don't give them guidelines, most clients will just provide a superficial response to their automatic thoughts. For example, Sophia had the thought, I'll never be a good therapist. It's a good thing that we provided her with a list of questions that she could ask herself at home, because without that list, she very well may have just said, that's probably not true. That's why we often give clients a list of Socratic questions, a worksheet called Testing Your Thinking, or a worksheet called the Thought Record. You'll find this list and the worksheets in your course manual. Sophia filled out both of these worksheets. You'll see them in the course manual. I'd like you to read them, and then look for the blank copies in the course manual so that you can fill them out about yourself. If you have any problems, please post your questions on the forum. Here's an important clinical tip. Wait until clients have fulfilled 2 criteria before you send the worksheets home or even the list of Socratic questions. The first is that clients really believe the cognitive model, that their thinking influences how they feel and what they do, and that by evaluating their thinking, they can feel better and act more productively. The second is that clients have demonstrated to you that they can successfully use the list of questions and fill out the worksheets right in the session with you. If they can't do it in the session, there's no way they'll be able to do it at home. Okay, part 3 of helping clients respond to their automatic thoughts. Sometimes evaluating automatic thoughts is actually not helpful, and we have to help clients develop a different relationship to their thoughts. Listen in as we discuss this problem at the Clinical Roundtable. When should we not help clients evaluate their automatic thoughts? And why shouldn't we at those times? And what should we do instead?
One time is when the thought is just patently true. So without even needing to evaluate it, we know this thought is 100% true, because if you evaluate it, you're not going to get anywhere. So in that time, in those kind of times, what you can do is go to either what's the impact of the thought, or just go straight to problem solving or some type of behavioral intervention.
And what kind of thoughts are patently true?
So my thinking is someone who's depressed and says, I don't want to get out of bed. So they're depressed, energy's low, and it's pretty sure that they don't want to get out of bed. But when they follow that thought with staying in bed, that's where you have the problem where mood's just not able to get better.
It would make no sense to say, what's the evidence that you don't want to get out of bed?
Yeah, exactly.
Yeah. Classic example would be with an obsession. I did have a patient who had the thought, the automatic thought, the intrusive thought, that he was on a ball spinning in space.
An image, too?
Yes, the planet Earth.
Wow.
It was true.
Because the planet Earth does spin in space.
I don't ask, what's the evidence that we're on a ball spinning? Well, that was patently true, but what was really distressing him was the fact that he could not get this thought out of his head, and he was frightened of it. It meant that he was going to go crazy. It meant that he was out of control of his own thinking process. So we do not typically examine the evidence pro and con for obsessions, because at that point what's terrifying is the fact that thought is present in their mind. They cannot push it out at that point. So we tend to look at the function of that thought. We tend to look at what the fear they have of that thought and the beliefs they have about that thought popping into their mind.
What's one belief they might have about a thought like that?
Oh, I'm out of control.
Yeah.
I'm out of control,
thinking
which is
is
a
out of
belief.
control.
My thinking is out of control. I will not be able to function. I will not be able to focus on my work, focus on my family, focus on my life, because I keep having this thought of us, being on a ball spinning in space. Now, for an astronomer, maybe a cosmologist, that thought would be quite comforting and quite interesting and quite enjoyable. For my patient, it was terrifying.
Yeah.
And we might teach a patient like that we all have distressing thoughts and weird thoughts. Mm-hmm. It's not so much the thought that's the concern, it's how much attention we're paying to it and how much we believe it to be true. Mm-hmm. And that's very different than evaluating the
validity of the thought.
Correct.
Yeah.
Mm-hmm. It's a different way to handle it.
So it's kind of like focusing on the process of the thinking as opposed to the actual content.
Yes.
Which makes me think of a lot of people with depression too, where there'll be one negative automatic thought about themselves, which then they follow with thinking about all the other negative things about themselves. So, it'll take a long time to focus on each specific thought about themselves, about their life, about how it's going to be. So what you can do then is focus on what's the process of rumination going on here? What are the advantages? What are the disadvantages? Mm-hmm. To look more, like you said, Norman, the utility.
Mm-hmm. If someone is ruminating or obsessing, instead of evaluating the thoughts, what would you work toward?
Well, one instance I saw with your father years and years ago, there's a patient that he saw for a consultation, videotaped, we all sat for, in which this patient had this depressive rumination, could barely get out of bed, and he wanted at that point to examine the automatic thoughts. He had read about cognitive therapy. He had read about focusing on cognitions, and your father said that he wasn't ready for that yet. That what he had to focus on at that point was behavioral activation, first getting out of bed, being able to do those things. And initially, the patient was disappointed. Mm-hmm. He was disappointed because he was seeing the father of cognitive therapy. He wanted to work on his cognitions. And here it is, the father of cognitive therapy telling him to work behaviorally. Right. But through the course of that session, the course of that consultation, he saw that was the right course of action. He wasn't quite ready to focus on the cognitions as yet.
And it sounds like you're saying when emotion's really intense, it's not a good idea to work on automatic thoughts, at least all the time. Another time, I think, is when clients are having a hard time accessing any emotion. So I have a lot of male clients who are emotionally avoidant, and any question you ask them goes straight to thinking. You ask them how they feel, they really don't know much going on there, so they focus on their evaluations. So in those cases, I just go to, okay, well, let's try to focus on what do you feel in your body right now? Where in your body do you feel this? Describe it to me. let me know how it feels. So I try to take away the thought aspect and just have them focus on the sensations involved in the emotion to try to get them more in tune. Because one of the coping mechanisms is to go in your head and to analyze, which takes you away from your emotional experience.
You know, you started to say something about what you might do when clients are experiencing a very high degree of emotionality right in the session. And you were saying maybe that's a time when we wouldn't immediately go to evaluating thoughts. So what do you do when patients have a very high degree of emotionality?
Patients appreciate learning that they can manage the emotion more than they believe they can. Mm-hmm. And I might do a very simple breathing exercise right then and teach them that they can do an intervention with themselves to take the emotion down a notch before they go on to do other work. Mm-hmm. And I think you actually mentioned that earlier, Norm.
Oh, yeah.
Yeah.
Combination of relaxation on one end and perhaps distress tolerance on the other.
That's right. That's what I was looking for, distress tolerance. That's right.
That they have nothing to fear from their own emotions. Some ways I just have ways of reframing people's emotions right when I see them. That sadness potentially could be seen as just being a signal to fill what is missing in life. That anxiety potentially can be seen as being energy to deal with a difficult or challenging situation. And rather than fearing these emotions, really in many ways to embrace them.
So when emotions are running very high, we might take it away from the thoughts that preceded that high degree of emotionality and talk about the experience of emotion, either when it's too high or if it's too low.
We talk about behavioral activation, just getting our very depressed clients up and moving. And sometimes I use the illustration, if it doesn't seem to be going so well, I'll use the illustration of the last time you were home with a bad cold. Do you remember when you decided to get up anyway, take a shower, get dressed? Did you feel any better than before that? And they'll say, yeah, that's right, I actually did. And so we'll use that as a metaphor for how important it is right now to get up and when you're depressed, to get up and get moving. And that might even be a behavioral experiment that they try to see if there's any difference in how they feel.